Thank you. So first up, we have a presentation recorded by Alison Boyce, and it's on pain comparisons with OI and other rare bone disorders. And Alison is a pediatric endocrinologist at Bethesda.
Thank you very much for the invitation to present on this important topic. Here are my disclosures. So bone pain can arise due to a variety of causes in rare skeletal disorders, many of which can overlap. Orthopedic pain may result from fractures, either current fractures or impending fractures. Bone deformities may result in pain, secondary lesions such as bone cysts or surgical hardware problems. Certain rare disorders are associated with metabolic deficiencies, such as vitamin D issues or high bone activity levels. Patients can have functional pain due to their gait or muscle issues. Neurologic pain can arise due to nerve compression or post-surgically. And inflammatory pain may involve the joints, tendons, or other parts of the bones. However, while this is a very comprehensive and nicely laid out list, we know that in reality, multiple of these issues can coexist at the same time. And this can make it very difficult to tease out the different causes of pain in rare bone disorders. So before getting into the specifics of pain types in OI and other disorders, I wanted to briefly review the different types of pain. The most common type of pain we think about when we discuss pain is nociceptive pain. This happens when there's tissue damage in the body, the bone or other tissue, and the signal travels through the peripheral nerves into the spinal cord and then up into the brain where it's perceived as pain. This is a very important type of pain because it serves as a protective function for the body, and it can be often perceived as sharp, stinging, dull ache, or throbbing. There is another type of pain that's much less frequently recognized, and this happens when there's a disruption within the nervous system itself. This is called neuropathic pain. Although patients may continue to perceive pain as being located in the bone or other part of the periphery, the issue is actually now in the nervous system, and it's divorced from any tissue damage that is now happening in the bone. This type of pain is often perceived as burning, numbness, or hypersensitivity. And this is a purely maladaptive type of pain. It doesn't do anything helpful for the body. So this is very relevant to fractures. Fractures are a common cause of pain in OI and other rare bone disorders. Right after a fracture, the nerves in the injured bone will release factors that increase pain signals from the nerves to the spinal cord and sensitize the nerves. So stimulation that would normally be very mild, such as just moving the bone a little bit, now will become very painful. And this is an example of nociceptive pain. However, we can also see neuropathic pain. This arises primarily if you have a chronic non-healed fracture. What can happen is you will have increased growth of the sensory nerve fibers in the bone in areas where you shouldn't normally have nerves. So this can lead to neuropathic pain, which again will be felt in the bone, but is actually a disorder of the nervous system. So pain and osteogenesis imperfecta is something that we have heard about a bit today. In addition to fracture pain, non-fracture pain is also extremely common, affecting up to 86% of patients, and is associated with poor quality of life. About half of patients with OI report that non-fracture pain interferes with their activities of daily living. And there are a number of reasons why this type of pain can arise. It can arise due to instability in the joints, especially the knees and ankles, which can be very hyperextensible. It can arise due to skeletal deformities in the spine, which leads to scoliosis, vertebral fractures, and spondylolisthesis. There can be nervous system complications, particularly in the skull. If patients develop basilar invagination, where the base of the skull infolds and compresses the brain, this can lead to headaches and other severe types of pain. And also, there can be intrinsic pain in the bone itself. This probably arises due to the fact that there's more bone breakdown in OI. So osteoclasts that resorb bone are highly present in our chewing the bone up, and this can be associated with pain. let's contrast that with another rare disorder. Fibrous dysplasia is a disease in which mosaic bone lesions develop because the skeletal stem cell differentiation is impaired. They're not able to form a normal bone type. Pain is very common in FD, affecting up to 80% of adults and 50% of children, and is associated with impaired physical function. Similar to OI, pain in FD can be quite complex and arise due to a number of causes. Skeletal deformities, again, are quite common here. This can include scoliosis as well as leg length discrepancies, which can place extra stress on the joints in the longer leg. Expansion of the skull can, similar to OI, lead to nerve compression and basilar invagination. Fibrous dysplasia can be associated with low blood phosphorus levels due to metabolic defects, and this is a common cause of pain and also growth problems such as rickets. This isn't typically seen in OI. Similar to OI, there is high bone activity in fibrous dysplasia. Again, you see there's a lot of bone breakdown and highly present osteoclasts or bone resorbing cells, which we think can contribute to pain. So a third disorder I'd like to address is achondroplasia. This is the most common cause of dwarfism. It arises due to mutations that affect how bones grow, and this can lead to shortened limbs, spine differences, and craniofacial differences. And pain is very common in achondroplasia, affecting up to 70% of patients, and this increases as they age. So similarly to the other disorders we've reviewed, pain in achondroplasia is complex. It can arise due to skeletal deformities such as leg bowing. Similar to patients with OI, these patients can have joint laxity and hypermobility that contributes to pain. Spine deformities, particularly kyphosis, and a really common complication of achondroplasia is spinal stenosis, where you have compression of the actual spinal cord itself, the large sac of nerves here, which can be quite painful and potentially serious. Also, patients with achondroplasia have craniofacial differences, and this can lead to deformities in the skull base, which can put compression on the cervical spine. And again, this can be a very serious complication. Although we see there are a number of similarities here related to deformities and spine problems, one important difference in achondroplasia is that bone activity is overall normal. While the growth plates themselves form abnormally, leading to the shortened limbs and other skeletal differences, we don't see that high bone activity that we see in OI and fibrous dysplasia, and we don't see an increase in those osteoclasts. So we don't think we're seeing the same type of metabolic pain in achondroplasia. I wanted to spend a little bit of time talking about osteoarthritis. This is a very common problem in the general population, and I think it's a very common and underappreciated feature of rare bone diseases. So this is also known as degenerative joint disease, and it arises when tissues in the joint break down over time due to repetitive use or weight bearing. Here you can see a typical x-ray finding. In this normal x-ray, this is a knee joint, and you can see there's a fair bit of space between the upper and lower parts of the knee. In this patient with arthritis, this space has broken down over time, and the bones are now grinding together, which can be quite painful. And again, this is quite common as patients age. Arthritis is a really big problem in OI. This is a paper that compared rates of arthritis in patients with OI compared to the general population. And we can see up to 11% of patients with OI reported arthritis in at least one joint, which was more than twice the prevalence seen in patients without OI. We don't have these same quite as nice of a study in fibrous dysplasia, but there has been some reports of osteoarthritis, especially in the hip joint. You can see here compared to this normal joint where we have nice space, and in this joint we see bone-on-bone grinding. And so this is a quite common site of arthritis in FD. Interestingly, in achondroplasia, despite the fact that we have the same type of skeletal deformities, there is a decreased risk of osteoarthritis compared to the general population. The reasons for this aren't entirely understood. It's thought that the mutation that causes achondroplasia, a gene called FGFR3, might actually be protective for joint function. And there's research going on right now to try to understand this relationship just based on the observation that joints seem to be so well preserved in achondroplasia. So this is an important difference we can see between different disorders. So I mentioned before that fracture pain can be associated with multiple pain types, both neuropathic and nociceptive pain. And this is an important feature of OI and other disorders as well. Studies have shown that both neuropathic and nociceptive pain are common in patients with OI. However, only nociceptive pain is associated with decreased physical function. Interestingly, in children, there's no relationship between the type of OI that someone has and the amount of non-fracture pain that they have. And we think this is likely explained by neuropathic pain, which isn't always correlated with how much disease someone has in their skeleton. And this is very similar to the type of pain we see in patients with fibrous dysplasia. Similar to OI, we see both neuropathic and nociceptive pain. But patients with neuropathic pain tend to report higher pain levels and worse quality of life. And similarly to OI, there is no relationship between the amount of fibrous dysplasia someone has and the overall pain that they report, which is likely explained by this neuropathic component to the pain. So the approach to evaluating bone pain really varies depending on which disorder we're talking about, but there are some commonalities to everyone. So all patients who are reporting bone pain, regardless of their underlying skeletal disease, need a thorough patient history. They need to describe the onset of the pain, what makes it worse, where it's located, where it radiates to, what medications it responds to, etc. And all patients need a detailed musculoskeletal exam, which should include evaluation of strength, range of motion, and their gait. Imaging and labs are another really important part of evaluating bone pain, but this needs to be individualized, depending on the disorder the patient has and their other individual factors. So treatment approaches for pain, again, there are both commonalities and differences between disorders. In all three of the disorders we've discussed so far, mechanical stabilization can be really, really important to try to correct and prevent skeletal deformities, to preserve function and decrease fractures. However, it's always important to note that any surgery can also lead to pain down the road due to orthopedic problems, hardware issues. So here we see an example of a staged correction of femoral bowing in a patient with OI using rods. Here we see a similar femoral neck stabilization in a patient with fibrous dysplasia. This is a really important procedure that can relieve pain due to orthopedic issues. And here we see a patient with achondroplasia who has undergone a very common and important procedure called a foramen magnum decompression. Due to their craniofacial difference, the hole at the base of the spine where the base of the skull where the spine comes out can get narrowed and compress the spine. So this hole needs to be tunneled out and made larger. So this can be important to relieve pain. Physiatry is a really important approach to treating bone pain that I think is common to just about every skeletal disorders. Physiatry or rehabilitation medicine is important to optimize muscle strength. This is particularly true because the bones and muscles are tightly integrated, and improving the muscles can improve the bones and vice versa. Correcting posture is critical. When patients have decreased core strength, this leads to a slumped type of posture. It can lead to increased pressure on the hips, on the neck. It can lead to tightening of the heel cords, and all of these things can compound pain and make it worse. Also, making sure that we're improving alignment as much as possible. I think leg length discrepancy is a common cause of pain because, as I mentioned, when the legs are unequal, it increases stress on the hips, the spine, the neck, all the way up through the entire body. Also, posture in wheelchairs and other assistive ambulation devices is really important to make sure we're optimizing function. Then I wanted to just end by briefly touching on bisphosphonates, because I think this is a critical part of managing pain, but only applies to certain rare diseases, including OI. So bisphosphonates are a medication that incorporates into the skeletal matrix and decreases the activity of osteoclasts, that are those bone-resorbing cells. It's been approved by the FDA and the EMA for about 20 years now to treat low bone density and bone tumors. However, there's also evidence that it can be helpful for pain in disorders that have high bone activity. So as I mentioned, that applies to OI and to fibrous dysplasia. However, because underlying bone in achondroplasia has normal metabolic activity, this is not the type of treatment that would be helpful. So how do bisphosphonates treat pain? This is an area of debate, but in general, this is how we think it works. In the bone-resorbing cells, the osteoclasts, treatment with bisphosphonates will reduce their acid secretion. Acid is one of the ways they break down bones. When they reduce acid secretion, they reduce signaling to the peripheral sensory nerves. When the peripheral sensory nerves are not signaling as much, they will produce less inflammatory cells, and that will reduce inflammation in the nervous system. The combination of all of these factors leads to reduced pain. So this is our current approach to using bisphosphonates in disorders such as OI and FD that have high bone activity. We start with mild pain by treating with over-the-counter medications such as Tylenol or paracetamol. And then if pain is moderate to severe and persistent, that's when we think about using potentially IV bisphosphonates such as zoledronate or pamidronate into our arsenal. This should be combined with adjuvant medications, particularly in patients who have neuropathic pain, which may need to be treated with gabapentin or other medications that modulate nervous signals. So I'd just like to, again, thank the organizers for inviting me to participate, acknowledge my group at NIH, as well as the support from our institution. Thank you very much for your attention.